Hello, my name is Dr. Dewan S. Raja. Today I will discuss about anatomy of palm of the hand. We'll go through the skin, the aponeurosis, the palmar aponeurosis, the muscles, intrinsic muscles, long flexor tendons from the forearm, and go through the blood vessels like the superficial palmar arch, deep palmar arch, nerve, the ulnar nerve, and the median nerve. So first of all, let's get some idea about the palm. This is the palm. This is the distal end of the upper limb, and the skin here is very thick skin, and skin has no hair, and skin has no sebaceous gland, but certainly it has sweat gland. Okay, and the fingertip here are rich with sensory receptor like uh, Meissner's corpuscles. Okay, also the free nerve endings. So we have sufficient number of, or maybe rich, we can say rich number of cutaneous sensory receptors here, so we can easily touch and feel something. It is a great tactile part of our body. And we have crease, multiple crease here. Okay, this crease has some clinical importance, especially in case of trisomy 21 in Down syndrome. We may get only one crease. That is called simian crease. Okay, we may not get multiple crease, we may get only one crease. And the skin over the palm is fixed because the superficial fascia, the aponeurosis superficial fascia is connected to the deep fascia by fibrous bands. Okay, and this is the thenar eminence, this is the hypothenar eminence. Now we'll go to the palmar aponeurosis. Palmar aponeurosis is located under the skin, a triangular sheet of connective tissue in the palm, and is continuous with the palmaris longus tendon. So this is the palmaris longus tendon. This is one of the flexor tendon. Thenar and hypothenar fascia. We have fascia over the thenar muscle and hypothenar muscle. Flexor retinaculum, there is the thickening of the fascia here. This is the flexor retinaculum, the distal part of the radius ulna. This is the thickening of the deep fascia of the forearm. There is attached to the carpal bones. Okay, so that is the flexor retinaculum, deep fascia thickening that is connected to the carpal bones on two sides, make a tunnel, make the carpal tunnel. So the palmar aponeurosis is also connected to the flexor retinaculum and with the metacarpal ligaments. We have the metacarpal, this is the superficial transverse metacarpal ligament. It is also connected to the palmar aponeurosis. Palmar aponeurosis protect the underlying structure, it helps in good grip. Okay, and also it is a site of origin of some muscle like that of the palmaris brevis muscle, very thin muscle on the hypothenar area. This muscle takes origin from the palmar aponeurosis. So it has multiple function. Okay, so the palm of the hand, we have 20 intrinsic muscles of the hand, thenar muscles, abductor pollicis brevis, flexor pollicis brevis, opponens pollicis, adductor pollicis. We have to identify in our dissection hall these muscles. Hypothenar muscle, palmaris brevis, abductor digiti minimi, flexor digiti minimi, opponens digiti minimi. We have four lumbricals. They take origin from the flexor digitorum profundus tendon, and we have four palmar interossei and dorsal interossei. So we have 20 intrinsic muscles. Intrinsic because they take origin, insertion in the hand. In addition to the intensive muscle, we have extensive muscle like the flexor, long flexor tendons, like that of the flexor pollicis longus, flexor digitorum superficialis, flexor digitorum profundus. Okay, those are the extensive muscle. So muscles of the palm of the hand. Here is the abductor pollicis brevis muscle. This is the fibrous pollicis brevis. This is the adductor pollicis oblique head. This is the adductor pollicis. This is the transverse head. Okay, these are the thinner muscles. What is the not supply of this muscle? They are mostly supplied by the median nerve, except the adductor pollicis, which is getting innervation from the deep branch of the ulnar nerve. Okay, and we have long tendon, as I discussed previously, long tendon going underneath the flexor retinaculum. Flexor retinaculum is a thickening of the deep fascia of the forearm. It is attached to the carpal bone on two sides. Okay, so it make a tunnel for the long tendon, flexor digitorum superficialis, flexor digitorum profundus, and flexor pollicis longus. Plus, this tunnel also contain the median nerve. If that is compressed, that we will get the carpal tunnel syndrome, or if we have dislocation of the lunate bone by carpal bone, that may also lead to carpal tunnel syndrome. Okay, this is the common synovial sheath here, and also we have synovial sheath for the tendons, long tendons here. It is not continuous in the second, third, and fourth finger, but the ring finger, pinky, it has the synovial sheath, and it is continuous with the common flexor tendon synovial sheath, and that may be continuous with this of that common flexor tendon sheath. Okay, that is usually continuous, but maybe discontinuous also. This is the tendon for the flexor. This is the synovial sheath for the flexor pollicis longus. That is also continuous with that, may not be continuous. This 1, 2, 3 are non-continuous. So if we like to prick a finger, we'll prefer to prick this, or that. We'll avoid that and that because there's a chance of spread of infection. There may be development of tenosynovitis. Okay, we got the muscles here. These are deep muscles. Here we'll get the deep muscle. There is opponent's pollicis, adductor pollicis, oblique head. Again, we are getting that, and we are getting some interosseous muscles. These are the dorsal. There is a dorsal interosseous muscle, and we should also get the palmar interosseous muscle here. Okay, these are deep muscles. Okay, we have the flexor digiti minimi brevis here. So deep muscles are these. The interosseous muscles are the deep muscles. Okay, we got that. Here, long flexor tendon like flexor digitorum superficialis, it split, and it will end up on the side of the second phalanx. The gap between the splitting of the flexor digitorum superficialis is the passage for flexor digitorum profundus. This is flexor digitorum profundus. It will insert to the base of the distal phalanx. So flexor digitorum for the distal phalanx, flexor digitorum superficialis end up in the middle phalanx, and the gap between the flexor digitorum superficialis is the passage for flexor digitorum profundus. Okay, we got like this. This is flexor digitorum superficialis. This is flexor digitorum profundus. These usually end up here, superficialis. Profundus go to the base of the distal phalanx. So again, this is synovial sheath here. This is the synovial sheath, common synovial sheath. This is the called ulnar bursa. This is the radial bursa. Okay, bursa means collection of synovial fluid. Okay, we have the interosseous muscles. As I told, these are the deep muscles. We have the palmar interosseous muscle, dorsal interosseous muscle. Palmar interosseous muscle may be 3, maybe 4. Okay, so these are unipinnate muscle according to the fiber direction, but dorsal interosseous are the bipinnate muscle, like this, like that, two-way muscle fiber orientation. and dorsal interossei for abduction. We have the middle finger is the axis, so anything away from that is the abduction. The palmar interossei for adduction. So how about the middle finger? Anyway, it goes this, that, both way it has abduction. Okay. So this muscle takes origin from the metacarpal, inserts to the dorsal hood, dorsal digital expansion, dorsal hood. Like this muscle take origin from the metacarpal bone, inserts to the base of the metacarpal and to the base of the dorsal hood. Okay. Nerve supply of these muscles, palmar interossei, dorsal interossei, nerve supply is from the ulnar nerve. Okay. If these are paralyzed, then we'll develop claw hand. We'll develop claw hand if the ulnar nerve supplying the interossei is lost, then we will develop claw hand. Claw, C-L-A-W, claw hand. Okay, we got that. Then we'll go to the superficial arteries and nerves of the palm. Okay, superficial artery with the superficial palmar arch formed by the direct continuation of the ulnar artery. So this is the ulnar artery here. Okay, continuation ulnar artery, and it is completed by the superficial branch of the radial artery, maybe directly superficial branch of radial artery, maybe from the arteria radialis indicis, arteria princeps pollicis may complete the superficial palmar arch. It lies deep to the palmaris brevis muscle and the palmar aponeurosis. It is under the palmar aponeurosis. It is superficial to the flexor tendon of the fingers. Okay, look at that. This is the tendon. It is superficial over the tendon of the finger, long tendons of the finger. It is also superficial to the lumbrical. So this is the lumbrical muscle. This origin from the flexor digitum profundus tendon. Okay, we got that. So superficial to the flexor tendon of the finger, lumbricals, and digital branches of the median nerve. So if you look at that, this is the median nerve. These are the digital branches, common digital branch, then digital branch proper. So our superficial palmar arch is over it, and upper limit of the superficial palmar arch, the level of the extended thumb here. Okay, at the level of the extended thumb, this is the level of the superficial palmar arch. From there we'll get some common digital arteries, then the proper palmar digital arteries. Okay, we got that. Now we'll go to the next slide. There is the deep palmar arch. This is formed by the direct continuation of the radial artery. This is the radial artery, ulnar artery are branches of the brachial artery. Okay, it is completed medially at the base of the fifth metacarpal here by the deep palmar branch of the ulnar artery, and this arch is related to the arch-like orientation of the ulnar nerve. Okay, this is the ulnar nerve here. Okay, it lies deep to the flexor tendons of the finger and the lumbricals. It is deep to the flexor tendons. Okay, it is little bit proximal to the superficial palmar arch. Superficial palmar arch is around 1.5 to 2 centimeter proximal to the deep palmar arch, around 2 centimeter proximal. Okay, innervation of the median and ulnar nerve. Yes, ulnar nerve supply most of the muscles, but the thinner muscle, especially this is the muscle, this thinner muscle, abductor pollicis brevis, flexor pollicis brevis, opponens pollicis are innervated by the median nerve, adductor pollicis innervated by the deep branch of the ulnar nerve. All the hypothenor muscles are innervated by the ulnar nerve. Palmar interossei, dorsal interossei innervated by the palmar nerve. How about the lumbrical muscle? First and second lumbrical by median nerve, third and fourth lumbrical by the ulnar nerve. So lumbrical has dual innervation, like brachialis muscle, dual innervation. Pectoralis major muscle, subscapularis muscle has dual innervation. Okay. We have to give emphasis on synovial sheath. Many long tendons entering the hand are surrounded by synovial sheath. Synovial sheaths on the second, third, and fourth digit are independent and are closed at the level of the head of the metacarpal. Common synovial sheath, ulnar bursa, contain the flexodigitorum, superficialis and flexodigitorum profundus tendon, and this tendon are coming through the carpal tunnel that is from over by the flexor retinaculum, below by the carpal bones. Okay. It continues with the little finger synovial sheath. Synovial little finger means the fifth finger. This is the little finger. So we have the synovial common sheath. It is continuous with that of the little finger. Okay. Synovial sheath for the flexor pollicis longus covers the tendon of the flexor pollicis longus and okay, and is continuous with the common synovial flexor sheath. So here also continuity. Only second, third, fourth we have the digital synovial sheath. It is not continuous with that of the common synovial sheath. Usually not. We must emphasize on this sentence: synovial sheath may be the route of spread of infection. Okay. Clinical anatomy, you have to give emphasis. Hand may be injured due to any region. Dupuytren's contracture, thickening of the palmar aponeurosis, especially on the medial side, and the finger will be flexed. The exact cause of Dupuytren's contracture is not known. It may be due to trauma, it may be due to alcoholism, it may be idiopathic. Boxman contracture, muscle may be paralyzed. Okay, long tendon muscle, long muscles may be paralyzed, so the tendon will not work in that situation. There will be flexion deformity because of muscle atrophy. In Boxman contracture, that may happen due to supracondylar fracture, anterior compartment syndrome, so muscle may be atrophied and there will be flexion deformity. Carpal tunnel syndrome, this is the flexor retinaculum. Under the flexor retinaculum, we have the 9 tendons. 4 flexor digitorum superficialis, 4 flexor digitorum profundus, 1 flexor pollicis longus, plus the median nerve that will make compressed. The median nerve is compressed. Compressed will get the carpal tunnel syndrome. Tenosynovitis, as we mentioned, synovial sheath infection may spread, and we may have inflammation of the tendon and the synovial sheath. Trigger finger, sometimes suddenly one finger may be flexed because the gliding activity of the synovial sheath is disturbed for some reason. There may be ball formation, so suddenly one finger may be flexed, okay, and it may not go back to the original position, or that may be due to the narrowing of the synovial passage of the tendon, or there may be some block, there may be fibrous band, or some ball valve has been developed. Okay, it can be managed conservatively or maybe by surgery. Usually by conservative way, people used to use a metallic immobilizing product from the grocery, and it is put here, and usually it will heal by itself. That is the metallic splint. Okay, that splint is used. Trigger finger, we got claw hand. Claw hand is a condition when ulnar nerve is damaged, and hand will be like this, claw hand. Okay, especially the two finger, the little finger and the ring finger will be more flexed than that of the other finger. There is a claw hand. Okay, we discussed the cutaneous innervation. This part, 1.5 finger, palmar aspect, ulnar nerve, rest part, median nerve. Okay. Ulnar nerve also innervate the dorsal aspect of the hand. Okay. Median nerve also give carry cutaneous sensation from the nail bed of first, second, and third fingers. And that's all about the anatomy of the palm of the hand. If you have any question, please feel free to ask me. Please share the information with your friend. Please support my channel. Please subscribe me. Have a nice day. Bye now.